Okay. Patient who undergo rapid deceleration motor vehicle collision for more than 3 centimeters are at risk of blunt thoracic aortic injury, complete aortic rupture, full thickness tearing through intimal, medial, and adventitial layer, typically results in rapid exsanguination and death prior to hospital arrival. However, incomplete rupture adventitia still intact may allow patients to survive long enough to receive medical attention. Likewise, patients with a complete rupture contain a hematoma or surrounding tissues, as likely occurred in this patient, may survive the initial injury but require expedient evaluation and management to prevent bleeding. They will likely be in hemorrhagic shock, hypotension, collapsed neck vein, pale, and cool extremities. Although external signs of blunt chest trauma, bruising, steering will imprint are concerning for blunt thoracic aortic injury, There are no clinical findings for specific aortic injury. Chest X-ray findings suggestive of blunt thoracic aortic injury, like widened mediastinum and left-sided effusion due to hemothorax, which explain these patients' diminished breath sound to the left. Concomitant injuries, rib fracture may be present. Diagnosis of blunt thoracic aortic injury can be confirmed by CT angiography for hemodynamically stable patients. Tracheoesophageal echocardiography likely in the operating room for unstable patient. Although hemodynamic support fluid blood product is indicated in hypotensive patient, systolic blood pressure is generally kept less kept at less than 100 millimeter to prevent injury, extension, and rebleeding while waiting emergent operative repair. Okay. Do you know about cricket? Like, do you know about cricket? One kind of sports. Have you heard about this? Okay. Okay. I am telling. It is related to medical. So I am telling you a story. Like one of the celebrity, like one of the cricket player in our country, suddenly develops sudden severe chest pain, shortness of breath. He he went to the nearby hospital, and they diagnosed that he has a myocardial infarction. So after giving the loading dose, the chest pain improves some sort of, and the local hospital told him to do the primary PCI immediately, but he rejected. Then within 5 to 10 minutes, he is in shock, like cardiogenic shock, and after 22 minutes of CPR, he regains his consciousness regains, and primary PCI done on that setting. Okay, it is not uh, uh, it is not the main part of this story. Main part of the story is after like after the PCI, the his consciousness regains like after 24 hours. Then he went to then in the hospital he actually have done smoking, like he takes 1 to 2 cigarettes in the hospital. And then when the doctor reveals this things that they actually told them not to do smoking, not to do smoking in that setting, like you are in very devastating condition, don't do it. He has done smoking, and then when the doctor reveals this thing, he starts taking action on that doctor who has done primary PCI. And now uh, he's now okay, and now as he is okay, as he does not our problem in our country, like those who are celebrity, those who are big people, they do not trust in our they do not trust in our doctors. So after doing PCI, he wants to go to, like, he wants to go to Singapore or Thailand to do further better treatment. I don't know. I don't know why people are like that. Is the is this because of their education, or what is the problem? Like 10 years before, same type of celebrity came to a hospital, and he rejected to do the PCI on that setting, and he died after 2 to 3 hours. And then the local people actually attack the hospital and do some damage in the hospital. That is the scenario of our country. Okay, sorry. Our medical system is not bad, but our people are crazy. They have lots of trust issue. That is the problem. Uh, uh, this is the problem. Yes, and the traditional way actually kills lots of people. Okay, next. Sorry. Platelet is slightly low. How many weeks? Days. Cytomegalovirus does not cause lung in. Yes. Oh, Okay, Aspergillus. Aspergillus is a ubiquitous fungus. Aspergillus is a ubiquitous fungus that most people encounter daily. Conidia are inhaled into the lung that and convert to potentially pathogenic hyphae. Infection is rare in immunocompetent patients as macrophages, neutrophils, and T cells rapidly neutralize and clear the organism. However, patients with severe immunocompromise, prolonged neutropenia post-transplant are far more likely to develop invasive disease. Invasive pulmonary aspergillosis is characterized by classic triad: fever, chest pain, hemoptysis. Fever, chest pain, hemoptysis. CT scan of the chest usually reveals nodules with surrounding ground glass opacity is halo sign. Diagnostic testing includes serum biomarkers for cell wall component, galactomannan assay, and sputum stain culture. However, sensitivity is low. Bronchoscopy with bronchoalveolar lavage and biopsy are required if non-invasive testing, sputum stain, or culture is inconclusive, as in this patient. Among lower respiratory culture, bronchoalveolar lavage has the high positive predictive value in the patients who have hematologic malignancies and or are hematologic transplant recipient. With one to Patients are treated with 1 to 2 weeks of IV voriconazole plus echinogandin caspofungin and then transition to prolonged therapy with oral voriconazole alone. The mortality is 50%. The mortality rate is more than 50%. This patient's pancytopenia is likely due to recent stem transplant combined with immunosuppressive therapy. Yes, cytomegalovirus is a common cytomegalovirus is a common opportunistic infection that may cause pneumonitis, marked by dyspnea, non-productive cough, low-grade fever, usually patchy or diffuse granulous appearance on CT scan. This patient hemoptysis, chest pain, productive cough, and nodules with a halo sign okay. Nodules with a halo sign is more likely to have aspergillus. Okay, CMV can cause pneumonitis, but it does not cause halo sign like these aspergillus, where it is written halo sign. Okay, pneumocystis pneumonia. Pneumocystis pneumonia, a common opportunistic infection characterized by dyspnea, non-productive cough, fever, and usually bilateral diffuse interstitial infiltrate on chest imaging. Hemoptysis, productive cough, and a halo sign on chest X-ray make the diagnosis less likely. Okay, sorry. Reactivation of the pulmonary TB commonly occurs in patients with immunosuppression, may manifest with fever, hemoptysis, dyspnea, upper lobe pulmonary disease. However, with nodules, thick sputum and nodules with surrounding ground glass opacity are more characteristics of aspergillus. Okay, yes, invasive aspergillosis. Invasive aspergillosis is immunocompromised neutropenia, glucocorticoid HIV. Invasive aspergillosis manifestation is triad of fever, chest pain, hemoptysis, pulmonary nodules with halo sign, positive culture, positive cell wall biomarker, galactomannan and beta D glucan. Management is voriconazole with or without caspofungin. Chronic pulmonary aspergillosis, it is lung disease or damage, cavitary TB. Manifestation more than 3 months of weight loss, more than 90% more than 90% cough, hemoptysis, fatigue. cavity lesion with or without fungus wall, positive aspergillus, IgG serology. Management is resect aspergilloma if possible, azole medication, voriconazole, and immobilization if severe hemoptysis. Okay. Like the barking cough. Uh, Barking. So it's group. Acute laryngotracheobronchitis. Is it like uh, epinephrine? Epinephrine, yes. I think that. I think so. You want to do intubate. You want to do intubation. Yes. And emergency mechanical ventilation like epiglottitis, isn't it? Okay. For epiglottitis is emergency intubation. For group like the rest make epinephrine. Okay. Okay. Croup is a viral illness that causes laryngeal and tracheal inflammation. Laryngeal or tracheal inflammation leading to subglottic edema and narrowing. The classic presentation include a barky. Classic presentation is a barky seal-like cough, inspiratory stridor. Mild cases are treated with a single dose of corticosteroid dexamethasone to decrease the airway edema. Stridor at rest. Severe croup, such as this patient can develop in those with progressive airway swelling and obstruction, and these patients are treated with nebulized epinephrine in addition to corticosteroid. Nebulized epinephrine constrict mucosal arterioles in the upper airway and alters capillary hydrostatic pressure, leading to decreased airway edema and reduced secretion. After administration, patients are often patients are observed for after administration patients are observed 4 hours because symptoms can recur. Patient needing multiple doses of nebulized epinephrine typically require hospital admission. Intubation with mechanical ventilation is reserved for those who have failed treatment with corticosteroid and nebulized epinephrine and have signs of impending respiratory failure, altered mental status, poor respiratory. Okay. Okay. This patient's intermittent cough, chest tightness, and shortness of breath worse at night. Shortness of breath worse at night are hallmark of asthma. Asthma is the most common Asthma is the most common pulmonary disorder encountered during pregnancy. Roughly one third of the cases improve, one third are stable, one third are worsen. Patients with history of severe or poorly controlled asthma are prone to develop unstable disease during pregnancy, typically worsening in the second trimester. The immunologic and endocrine changes during pregnancy can also rekindle previously resolved childhood asthma. Asthma presents similarly in pregnant and non-pregnant patients, cough, wheezing, dyspnea, chest tightness. Symptoms are typically intermittent and may be exacerbated by weather changes, especially cold, allergens, infections, etc. They usually worsen at night, potentially due to circadian hormonal variation, low epinephrine glucocorticoid signaling causing reduced anti-inflammatory effects, or to environmental factor, dust mites or pet hair in the mattress. Wheezing may be absent outside of attacks. Asthma control is essential for avoiding maternal or fetal complications, preterm delivery, low birth weight, antenatal hypoxia. Most therapies are safe and generally involve inhaled short-acting beta-agonist albuterol. Acute symptoms: inhaled corticosteroids are required daily for persistent asthma. Oral corticosteroid prednisolone may be required for exacerbation. Gestational asthma can be confused with Gestational asthma can be confused with dyspnea of pregnancy, a common physiologic cause of shortness of breath, air hunger due to progesterone-induced stimulation of the medullary respiratory center. Although it worsens during second trimester, dyspnea of the pregnancy is persistent rather than intermittent and not associated with diurnal variation. It would not explain this patient's cough uh, and chest tightness. Sorry, I don't think so. Recurrent sinopulmonary infection is a sign of cystic fibrosis. Okay. Cystic fibrosis. Cystic fibrosis is an autosomal recessive disorder caused by mutation in the cystic fibrosis transmembrane conductance receptor gene. Cystic fibrosis transmembrane conductance receptor gene defective chloride transport via CFTR causes the mutation of thick dehydrate mucus in the respiratory tract, which allows bacteria to proliferate and invade the sinus. Most cases are identified on newborn screening. However, because screening does not detect less common CFTR mutation, a minority of the cases are not identified until the patient is symptomatic. Detection of the elevated sweat chloride concentration is diagnostic. Characteristics findings of cystic fibrosis include recurrent sinopulmonary infection, digital clubbing due to chronic hypoxia. Virtually all patients with cystic fibrosis develop chronic rhinosinusitis. Up to one-third of the nasal polyp, benign outgrowths of the inflamed mucosa that form as a result of chronic infection and appear as shiny gray masses. Polyps obstruct the nasal passage and exacerbate sinusitis. Management include intranatal glucocorticoid for symptomatic relief and in some cases surgical resection. In addition to respiratory features, pancreatic insufficiency leads to malabsorption, resulting in poor growth and deficiency of fat-soluble vitamins A, D, E, K, epistaxis. Okay, okay. Eosinophilic granulomatosis with polyangiitis, Sharp-Strauss syndrome, is a systemic vasculitis characterized by chronic rhinosinusitis, including nasal polyps, asthma, prominent eosinophilia. It is typically diagnosed in adulthood and diffuse wheezing would be expected. And C, D. Severe allergic rhinitis can predispose. Severe allergic rhinitis can predispose patients to epistaxis as well as recurrent sinusitis and nasal polyposis. However, lung disease with chronic hypoxia, RALS, and digital clubbing is not expected. Okay. Yes, arterial blood gas. Okay. ALS is a neurodegenerative disease that affects the upper and lower motor neurons throughout the day. Lower motor neuron involvement manifests as skeletal muscle weakness due to atrophy and fasciculation. Weakness of the diaphragm leads to paradoxical breathing, abdominal expansion due to during expiration rather than inspiration, with poor inspiratory strength, shallow breathing with low tidal volume, hypoventilation. Shallow breathing with low tidal volume, hypoventilation results in atelectasis and respiratory insufficiency. Respiratory insufficiency is compounded during sleep because decreased accessory respiratory muscle activity during the REM stage. In addition, in addition to airway collapse due to relaxation of the weakened pharyngeal muscle, therefore respiratory insufficiency may resemble obstructive sleep apnea with symptoms that include daytime fatigue and headache. Patient can also develop cognitive impairment caused by hypercapnia, chronic respiratory acidosis, as suggested by the patient's compensatory elevation in serum alcohol. Suspicion of respiratory insufficiency should be confirmed with ABG gas analysis. Uh, so, I'm calling you 1 minute. My father is calling. I was reading the explanation. Okay. Respiratory insufficiency is compounded. Respiratory insufficiency is compounded during sleep because of decreased accessory respiratory muscle activity during REM stage, in addition to airway collapse due to relaxation of weakened pharyngeal muscle. Therefore, respiratory insufficiency may resemble obstructive sleep apnea with symptoms that include daytime fatigue and headache. Patients can develop cognitive impairment caused by hypercapnia, chronic respiratory acidosis, as suggested by these patients' compensatory elevation in serum bicarbonate. Suspicion of respiratory insufficiency Suspicion of respiratory insufficiency should be confirmed with ABG analysis. Treatment focuses on improving respiratory function, which both prolongs the survival and improves the quality of the life. Non-invasive positive pressure ventilation assists respiratory function by opening the upper airway and providing positive and expiratory pressure to improve atelectasis. Okay, next. It's not heart failure. BNP is normal. It's not fever with cough, like it's not pneumonia. Patient has no fever. It's not pulmonary embolism. Pulmonary embolism, there is hypotension, tachycardia, tachypnea. Patient has hypertension, and he has a very long history of smoking, 40-year back story of smoking. So, smoking can cause COPD. These elderly patient with long smoking history likely has undiagnosed COPD. His presentation is consistent with acute exacerbation of the COPD characterized by a change one of the following characterized by change one or more than one of the following: cough severity or frequency, volume or character, sputum production, level of dyspnea. Physical examination is often remarkable for wheezing, tachypnea, prolonged expiration, and the use of accessory respiratory muscle. JVD may be observed especially during expiration due to intrinsic intrathoracic pressure. Hyperinflation can be seen on chest X-ray. Hyperinflation can be seen on chest X-ray. Explain the distant heart sound on auscultation. Upper respiratory infection is the most common trigger of COPD exacerbation. In this patient, upper respiratory infection is suggested by 1 week history of low-grade fever, runny nose, and productive cough. Next, is it aspiration? Why this is aspiration? Or what is the reason? Is it due to impaired esophageal motility or use of sedating antipsychotic medication? These patients, this patient develop fever, cough, pulmonary infiltrate more than 48 hours after being admitted to the hospital, indicating hospital-acquired pneumonia. The presence of poor dentition and apical right lower lobe infiltrate and polymicrobial sputum gram stain results suggest the underlying cause is bacterial aspiration pneumonia. Bacterial aspiration pneumonia develops when oropharyngeal or gastric microbes are introduced into the lower airways, subsequently overwhelm host defense mechanism due to large inoculum size or organism pathogenicity. Risk is increased in hospitalized patient due to swallowing, due to sedative and antipsychotic medication. These medications impair the cough reflex and often directly impairs the glottal function, which increases the quantity and frequency of aspiration. Use of gastric acid suppression and medication. These medication increase the pH of the stomach, which creates the permissive environment for microbe growth and glottal or pharyngeal disruption. Intubation, tracheostomy, NG feeding, and anesthesia may impair the ability to protect the airway and coordinate muscle movement with swallowing, which increase the frequency of aspiration and inoculum size. Other common risk factors for aspiration include poor dentition, dementia or delirium, and older age. Bacterial aspiration pneumonia generally causes fever, productive cough, and a pulmonary infiltrate in a dependent portion of the lung. Apical segment of the right middle lobe. Most cases are caused by aerobic upper respiratory organism, but anaerobes are often present in the setting of lung abscess or empyema. Impaired esophageal motility, common cause of aspiration, but patients generally progressive difficulty of with solid and liquid over weeks or months. It is unlikely this patient has an acute change in esophageal motility while hospitalized that lead to aspiration. Alkalosis. and he has hypoxemia too. Xemia, PCO2. Aspiration pneumonitis comes with fever, levetiracetam. Yes, that's true. Is it fat embolism syndrome? Maybe it is drug. Maybe. Or maybe it is fat. This patient most likely has fat embolism syndrome. The condition can occur 24 to 72 hours following fracture, 22 to follow for 72 hours following fracture or surgical manipulation of bone that contained abandoned marrow, femur, pelvis. The marrow consisting of fat hematopoietic cell embolizes into the venous circulation and can cause physical obstruction in the pulmonary capillaries. Some of the emboli some of the emboli may pass through the pulmonary circulation to cause microvascular occlusion in the systemic circulation, brain, dermal capillaries. The circulating fat globules likely also include a systemic inflammatory response that further contributes to microvascular dysfunction. Patients with fat embolism syndrome classically have the triad respiratory distress, neurological dysfunction, and confusion, and a petechial rash. The rash is present less than half of the cases. Thrombocytopenia may occur due to platelet adherence and aggregation to the circulating fat globules. Patients have developed pulmonary edema mimicking acute respiratory distress syndrome after 24 to 48 hours, seen in this patient with bilateral ground glass opacities on chest X-ray. No pulmonary arterial filling defects are seen because the emboli obstruct the pulmonary capillary and are too much to be detected on CT scan. Cardiogenic pulmonary edema would explain this patient's respiratory distress. However, would would not explain the confusion unless cardiogenic shock is present. This patient's lack of hypotension rules out the shock. And drug-induced hypersensitivity in the form of drug reaction with eosinophilia and systemic symptom stress is commonly seen in certain epileptic drugs like lamotrigine, carbamazepine. Levetiracetam is not a common culprit. Patients may have respiratory distress and confusion systemic due to systemic organ involvement, but a macular rash is not. But a macular rash is also expected because it is the most common manifestations of stress. Next, I'm thinking. Okay. This patient's long-standing cough, systemic symptom, weight loss. Systemic symptoms, weight loss, malaise, night sweat, leukocytosis, and right lower lobe cavity indicate lung abscess. Most patients are caused by aspiration of the oropharyngeal anaerobic bacteria into the dependent portion of the lung due to periods of impaired consciousness, alcohol, drug abuse, seizure disorder, or swallowing dysfunction. Patients with Parkinson's disease, loss of dopaminergic neuron control, loss of dopaminergic neurons that control the striated muscle, loss of dopaminergic control that controls the striated muscles in the oral cavity, pharynx, and esophagus, which causes progressive swallowing dysfunction and significant increase the risk of aspiration. Coughing during eating is important. Coughing during eating is often an important clue. Lung abscess generally presents with indolent fever and cough, productive of foul-smelling sputum. Systemic manifestations such as night sweat, weight loss, malaise are often present. Lab evaluation frequently reveals leukocytosis and signs of chronic inflammation, anemia of chronic disease, thrombocytosis. The diagnosis is generally confirmed when chest imaging reveals cavitary infiltrate in a dependent portion of the lung, superior segment of the lower lobe, and posterior segment of the upper lobe. Okay, yes. Lung cancer can cause subacute weight loss, malaise, cough, anemia, thrombocytosis, and a cavitary infiltrate in the setting of squamous cell carcinoma. However, the presence of swallowing dysfunction with fever, leukocytosis, productive yellow sputum make lung abscess more likely in this case. And TB reactivation can lead to cavitary lung lesion, subacute symptoms, leukocytosis. However, this patient with cavitary lesion in the lower lobe uh, in the setting of swallowing dysfunction is more likely to have aspiration pneumonia with subsequent lung abscess. Is it Ludwig angina? It can block the airway. Ludwig angina is a rapidly progressive cellulitis of the submandibular and sublingual space. Most cases arise from contiguous rather than lymphatic spread of polymicrobial dental infection in the submandibular molar. The contiguous spread results in bilateral edema, submandibular and sublingual space. As the submandibular area becomes tender and indurated, the floor of the mouth becomes elevated and displaces the tongue posteriorly, which may lead to acute airway obstruction. Additional clinical features of Ludwig angina include a neck that is often described woody, browny, but has no associated lymphadenopathy. As with other lesions that threaten the airway, patients with examination findings concerning for impending airway obstruction, drooling, inability to lay flat, and tripod positioning should have their airway secured, regardless of current oxygen generation. This is because oxygen saturation is often maintained until very rapid decompensation within minutes. Therefore, these patients require if needed, continued assessment if needed, intervention to secure the airway, nasotracheal intubation, and avoid tracheostomy should be done. Yes, infection with retropharyngeal space can present with dysphagia, hoarseness, shortness of breath. However, this is due to edema of the posterior pharyngeal wall rather than displacement of the tongue. It is most likely extend through the alar fascia uh, into the danger space. Alar fascia into the danger space, which can progress into posterior mediastinum and result in acute necrotizing mediastinus. Okay. But is it ARDS? Abnormal chest X-ray? Do a chest? We do nothing. Okay. This patient has sepsis due to ascending cholangitis. She soon developed pulmonary edema, wet crackles, new bilateral fluffy opacities on X-ray, uh, mm, opacities on X-ray, unexplained by volume overload, unexplained by volume overload, cardiac failure, uh, um, volume overload, cardiac failure, and given the normal jugular venous pressure and left ventricular function on echocardiography, the non-cardiogenic pulmonary edema resulted in several severe hypoxemia requiring high FiO2. Timing of the chest X-ray, euvolemic status, hypoxemia are consistent with acute respiratory distress syndrome, rapid source control, endoscopic stone retrieval, and antibiotic therapy reduce but cannot entirely eliminate the risk for ARDS. Sorry, I was reading the. Okay. Okay, this is non-cardiogenic pulmonary edema resulting in severe hypoxemia requiring high FiO2. Timing, chest X-ray, euvolemic status, and hypoxemia are consistent with ARDS due to sepsis, rapid source control, endoscopic stone retrieval, and antibiotic therapy reduced but cannot entirely eliminate the risk for ARDS due to uncontrolled hyperinflammatory response. Invasive procedure, biliary instrumentation are transiently increase systemic inflammation. When lung injury has a clear etiology, ARDS can be diagnosed with no further testing. A brief cardiac screening, ECG, troponin I, B-type natural neuropeptide, bedside cardiothoracic echocardiography is performed. Survival is maximal when specific intervention, low tidal volume ventilation, prone position are implemented promptly. Therefore, early diagnosis based on syndrome recognition rather than extensive diagnostic testing a time critical advantage. Okay. Okay. This patient with cystic fibrosis has non-resolving symptoms of lower respiratory inflammation, eosinophilia, has IgE, IG level more than 1000, finding consistent with allergic bronchopulmonary aspergillosis. Aspergillus species, usually Aspergillus fumigatus are ubiquitous environmental fungi continually inhaled and cleared by natural lung defense. Natural lung defense mucosity escalator in patients with structural airway disease, asthma, cystic fibrosis, recurrent infection, mucus trapping lead to chronic colonization and hypersensitization to the fungus spore Aspergillus. This promotes a T helper 2 based allergic response, driving production of IgE and eosinophilia. ABPA may be ABPA may be indistinguishable from underlying cystic fibrosis bronchopneumonia. Many fever, pneumonia, thick blood, streak, sputum are common. ABPA may be suspected if there is unexplained lung function decline despite and and appropriate antibiotic course. Diagnosis includes evidence of aspergillus specific sensitization, positive skin testing. AVPA may be suspected if there is unexplained lung infection despite and appropriate antibiotic course more than 1 weeks. Diagnosis includes evidence of aspergillus specific sensitization, positive skin testing, and specific IgEs. Chest radiology showing bronchiectasis and mucus plugging. Intravonchial exudates appearing as tubular finger in glove radio densities. In patients with cystic fibrosis, routine annual AVPA screening with total IgE is recommended. Treatment includes glucocorticoid to decrease allergic inflammation and antifungal therapy, voriconazole to reduce the spore burden. Okay, yes. Acute hypersensitivity pneumonitis can cause fever, malaise, pneumonia-like airspace, infiltrate, unresponsive to antibiotic therapy. Pneumonitis typically improves spontaneously in the hospital. Patient removed from in-setting exposure. Eosinophilia and high Ig is not expected in acute hypersensitive pneumonitis. And patient with cystic fibrosis bronchiectasis can be colonized. Sorry, simple or non-disseminated strong iloids, inhaled infection that can cause eosinophilic pulmonary disease, infiltrates with peripheral eosinophilia and elevated IgA. However, it usually occurs in rural, tropical, subtropical areas in addition because larva penetrates the skin and eventually swallowed. Patients usually have dermatologic roaming, urticaria, gastrointestinal obstruction, ileus manifestation. Okay. Okay, can we take a break? You have done your breakfast. I am okay. You have your breakfast.